Right, hello everyone. I think we're going to get started. Thanks for joining us. Welcome to this Health Foundation webinar on the implications of the recent spending review for the NHS, social care, public health over the rest of the Parliament. I'm Hugh Alderwick. I'm Head of Policy here at the Health Foundation, and I'm joined by an all-star cast of speakers and panelists. They'll introduce themselves when they speak, but we've got Saffron Caudry, who's Deputy Chief Exec at NHS Providers, Sarah Pickup, Deputy Chief Exec at the Local Government Association, Anita Charlesworth, Director of Research and the Real Centre here at the Health Foundation, and Dave Finch, who's an Assistant Director who leads lots of our work on wider determinants of health. So the background for the conversation today, if you're in the right place, is the spending review last month, which set out budgets for government departments up to 2024-25. We also had the announcement of the Health and Care Levy, a tax increase back in September, which has effectively allowed spending on health to increase over the rest of the Parliament without too much further squeezes on spending in other areas. And then yesterday, we had further details published by government on the new cap on social care costs, which we can talk about a little bit. Looks less fair, less generous than we previously expected. So the purpose of today is really to try and understand what the spending review and the related announcements mean for health and social care, and to hear what our panelists and speakers think we should make of it all. Before we get into the detail on health and social care, I think the overall picture from the spending review is that government's announced real terms increases in funding for most areas of government spending. Only 3 departments, health and social care, home office and education, are going to have higher spending by the end of the Parliament than in 2010. So as the IFS have said and put up nice charts on this, austerity is far from undone and the effects are going to be felt for some time. So a mixed picture, which we're going to hear more about. So before I hand over to the speakers, let me just talk through very quickly how the session's going to run. So we're going to start off with a presentation from Anita and Dave, setting out the overall picture for health and social care, with some scary and some less scary charts, true to form for Anita. Then we're going to go to Saffron and Sarah for some initial reflections. And then we're going to spend the second half of the session with questions for all 4 speakers, responding to all of them in different ways. So please do submit questions as we go. I think you can vote for the ones you like the most, so please do that as well. And I'll try and ask them or pick up on the general theme when I'm directing the questions around. There should be a box at the bottom of your screen. And thanks to everybody that's already submitted questions ahead of time, which were really good. And I've tried to weave them into some of the questions I've prepared. 2 final things. First, the session is being recorded and will be available on the website in the next 24 hours, I'm told, presumably so you can watch it all again. And second, if you want to tweet, please do, and use the hashtag THF spending review. I think that's all of the housekeeping bits. So firstly, I think it's over to Anita and Dave.
Thank you. Yeah, Dave's going to share his screen, which has got our slides on together, and he's going to, and we're going to do that annoying next slide, please, I'm afraid. So I'm going to cover the funding for NHS and social care, and then Dave's going to talk about public health and wider health determinants. So first slide, please, Dave. So the big picture is set out here. So the purple line is the planned increase in funding for frontline NHS services that was set out way back before the pandemic to deliver the long-term plan that was published at the beginning of 2019. And you may recall that that promised a 20 billion increase in real terms in the funding for the NHS by 2023-24. So what this spending review does is it then sets the budget for 24-25 for the NHS, and also sets out how much of the levy will be devoted to the NHS over this period on top of that planned funding pattern. And the result of that is the green line there when you exclude the cost of COVID. In fact, what we've spent is this red line. So obviously, there's been a huge amount of one-off costs as a result of COVID. As the OECD said this week, we have one of the highest direct spends on COVID, in part, obviously, due to the very high impact of COVID in this country, but probably also due to lack of preparedness and resilience in our system. Stripping out those costs, what we see is that funding now is going to increase by just over 3% a year for the rest of this Parliament. This means that, we're not like some other areas that are having very, very tight settlements, but really to judge how good this settlement is, you have to think about how it compares to pressures. And the thing I would just emphasise is obviously we'll have huge direct pressures for COVID, but COVID is not over and it leaves a lasting legacy on our system. And the last time we had to deal with such a big backlog of care, modernise our system was in the early 2000s, and then we had increases that were above 6% a year. So, this is a lot of money, but actually compared to previous times when we've tried to introduce fundamental changes and deal with major backlogs of care, it's not. Next slide, please. What is different, I think, as well, though, is it's not just day-to-day running costs. So I've criticised the government for a number of years now, where we've underinvested in capital and fallen behind even further OECD partners. So there is a significant increase in capital spending, and that does mean that for the next few years we're spending a share of GDP that's in line with OECD countries. But I think it's fair to say that that is beneficial, but also we need to be realistic about what that could achieve, because it comes on the back of years and years, as you can see, where the red line is below the blue line. And so there's that legacy of underinvestment, and we have a backlog of maintenance of over £9 billion. So this is good news, but it is far from a panacea. And if it is to make a difference, it will need to be sustained for a very long time. Next slide, please. On social care, I think the picture is that actually government hasn't learned a lesson here. So whereas we've seen that health spending on day-to-day health spending has been prioritised over long-run investment spending for many years, and in this settlement, finally capital spending is moving in line with day-to-day spending. Social care spending has fallen behind health spending. And actually the same is true here now as well. So the NHS over the rest of this spending review is getting an increase of over 3% a year. Social care is getting an increase of less than 2% a year. So this does mean that spending in 24-25 will finally be above the spending that we had back in 10-11. So that's the red line. But when you adjust for population change, which is the yellow, and then you adjust for the ageing of the population, which is the green, what you see is that by the end of this Parliament, we will still be spending less than 90% per age-adjusted head of population of what we were spending back in 2010-11. So that can in no sense, I think, be considered to have solved the social care crisis that we face here. This is stripping out the funding that will go specifically for the cap, which is obviously a separate issue. This is looking at the core of the adult funded social care system. Next slide, please. So on the NHS, there is more money going in, but as I've often said, more doesn't necessarily equate to enough. And one of the big issues, obviously, and the reason why more money is going in is because we've got an enormous backlog of elective care. And there's a huge amount of uncertainty about quite how that backlog will play out. But we're missing about 8 million people who we would have expected to come forward to care through the pandemic. If 75% of those people come forward, and we were to aim to get back to the 18-week standard by the end of this spending review period, then our estimates are that that will cost something like £17 billion. In this settlement, there is provision for us to spend £2 billion a year on the elective backlog, Some of that's gone in for this year as well. So that's £10 billion. So in fact, if we just wanted to hold the waiting list at something like 5.5 million, which is where it was in the early summer, we'd have needed over £13 billion. So this settlement is more money for the NHS. But if patients do reappear in the numbers that we might expect, then this isn't enough to really make any sort of inroad into the current size of the waiting list, and that size is unprecedented. Next slide, please. Finally, as well, the spending review said nothing really materially about the workforce, and actually all this money is good news, but actually it can't achieve anything unless we can recruit and retain the staff that we need. And COVID has shown that we've got huge capacity issues in our system, and those are legacy capacity issues. And this, again, settlement doesn't really talk about how we're going to deal with those fundamental issues around capacity for the longer term, so that we're not left in this sort of situation again. And this chart just shows that if you look at hospital beds per 1,000 or nurses per 1,000, we are below the OECD, we're below the G7, we're below the EU 14. We're in a small number of countries that run their system incredibly hot. Most of the other countries that do that on limited capacity are countries that are going through a stage of rapidly introducing healthcare systems and coverage in their populations. They're not well-established health systems. I'll hand over to Dave now.
Thanks, Anita. So, sorry, I lost control slide. So I was going to start by talking about the public health grant. The spending review and budget set out that this will be maintained in real terms over the spending review period. So that's better than it has been for the since 2015, where there had been successive cuts up until last year in real term cuts in the public health grants. And that's what the chart is showing on the black line, is how the public health grants had fallen in real terms since 2015-16, when funding was at a peak. And I think for us, one of the big concerns here is that maintaining it in real terms alone won't meet what our analysis shows is it won't meet expected future pressures for demand and costs. Some of that's coming from wage growth. Some of that is also reflecting underlying trends from before the pandemic, things like growing drug and alcohol deaths, rising obesity, and also projected rises in child poverty, which have an important effect on demand for things like children's services. And then on top of that, we can add some of the things that have happened through the pandemic. So even yesterday, publications showed how child obesity has risen quite significantly through the pandemic. So these extra growing pressures are unlikely to be met purely by maintaining the public health grant in real terms. The two projected lines on the chart there are showing what we have estimated it would take to restore the public health grant back to its real term per capita values, as well as accounting for those extra cost pressures and demand. So rather than that kind of flat real terms increase, it would have required an extra 1.3 billion a year by 2024, and we were phasing that in gradually over the spending review period in this chart. I think the other point to note here as well is that the shape of those cuts for different local areas has been different. When we've looked at the size of cut by deprivation, overall there are generally bigger cuts on a per capita basis in local authorities with a higher level of deprivation than in those with lower deprivation, which is kind of at odds with the government's levelling up agenda. We can also look at some of the specific functions within the public health grant. So this is showing how that change in spend, although overall there was a 25% per capita cut to the public health grant since 2015-16. Those cuts have been at a different scale for different elements of the public health grants. One of the biggest has been stop smoking services, which is around cut of around a third, which if we reflect that back to what's actually happened to sort of smoking prevalence, although it has been gradually reducing, there's still around 17% of the population are still smoke, and so there's still a kind of a fair rump to tackle, and the and things like drug and alcohol services, where there's been a 17% cut. We know that deaths in those areas have been growing in previous years. So although it's going to be maintained in real terms, it's still going to be it's not doing anything to particularly, well, to reverse these cuts at a local level, which means there's still going to be some significant challenges for public health going forwards when we add in the impact of the pandemic on health outcomes as well. The final thing I was going to reflect on a bit is looking a bit more widely, where we focus very much on health specific funding, but I think it's definitely worth taking a broader perspective, particularly when we know that the greatest influences on our health are actually the conditions we're living in. I think Hugh mentioned at the start that overall the settlement was for real terms growth across departments, including outside of for most departments, including outside of the NHS. So that's expected to grow by around 3% a year overall in real terms to 2024-25. I should say at this point that the numbers I'm using here are taken from analysis by the IFS and Resolution Foundation, so I should certainly credit them for their analytical work. But there are some of the funding has been on protected departments, things like education, where although that is growing above real terms growth over this period, it's only going to take spending back to where it was at around the start of the decade, which I think is an interesting comparison to make back to the NHS, where I think we come to expect that we'll invest greater amounts in the NHS as a wealthy society to improve our health, but we're not doing the same thing in something like education, which is really core to support our health through the lifetime over the long term. And then spend in unprotected departments, so that's most departments outside of the NHS and Department for Education, as well as some others, are still going to be a fifth lower than they were in 2009-10, which is just, I think, really to make this point that, again, echoing what Hugh said at the start, that although there's increased investment in departments, it's still not where it was over a decade ago. And I think it's particularly likely to be quite a tough settlement for those departments. And there's an added element of potential pressure there, where I think the spending review assumptions for spending on the NHS, the extra growth at the end of the period aren't as high as in previous years have been. So it's likely that there's going to be some extra funding pressure coming towards the end of the period, which has the potential to have a knock-on impact on those other departments. One area that is, again, very important for the conditions we're living in and shaping those conditions that influence our health is local government. Once the social care funding there has been taken out, they've got an average of around nearly 2% a year funding growth, which is, when we take account of the kind of the historic cuts that have gone to local government already, that's quite a tight position. And the reliance on council tax to raise revenue to meet service demands also suggests that there's that's likely to be more difficult for more deprived areas, where perhaps that revenue isn't as readily raisable, which suggests across kind of local government and national government we have quite a tight settlement on other areas of government outside of the NHS and Department of Health. And I think the final factor to think about is general living standards outlook. So this are the incomes of people. That's particularly weak over the next 4 years. That's partly about high inflation coming through. It's partly about weak wage growth, and it's also partly about the tax rises coming through, and some of the benefit cuts also that were made to universal credit. And I think that's a final thing to dwell on here, is that we'd anticipate that a tough financial outlook for families suggests potential for more financial strain and people struggling to make ends meet, particularly in a high inflation environment, which can all have knock-on impacts on people's health. And although there was actually significant and positive news on parts of the universal credit system at the budget, which was to reduce the taper in universal credits. This is how much of your benefits are withdrawn as your earnings increase, which is, it was a significant giveaway, but it's very focused. It's focused inevitably on working families because it's in relation to levels of earnings. And so that was doing very little to offset the overall impact of removing the £20 uplift for those families who aren't in work and with lower levels of earnings. So again, there are Resolution Foundation estimates of the net effect of those two things, leaving around 3.6 million families worse off. And those are those predominantly out of work who we typically think have lower incomes, so are already more likely to be in poverty and in a tougher financial position. So I realise that brings more doom and gloom into the outlook, but I think it's important to think about that kind of wider perspective, and also thinking about the health settlement.
Thanks, Dave, and thank you, Anita. Really clear presentations, and important to put the wider context around NHS social care public health spending, Dave. So appreciate you doing that. So before we get to the questions, I want to have some initial reflections from Sarah and Saffron. Sarah, can I come to you first and ask for your thoughts on particularly public health, social care in the context of the wider local government settlement?
Thanks very much. And I think David's remarks about the unprotected departments kind of fit very well with that. The DLUC department is an unprotected department, and that's where, well, it's not where most of local government funding comes from, because most of it comes from council taxpayers and business rates payers, but it's a really important part of funding. So I'm going to focus mainly on adult social care. But the key point here is that all aspects of the system have to be supported if any part of the system is to succeed. So, you know, the NHS can't succeed if there's lack of investment in social care, or not to the, you know, it can succeed in some things, of course, but not to the extent that the ambitions of the ambitions there are for the system. But just briefly to start, I'll start with public health, which David has really already covered. There's no real terms increase, as he said. It's hard to see how this supports a drive to reduce health inequalities and improve population health, which actually is the heart of the purpose of every integrated care system, linking it to the reforms going through in the bill at the moment. So not increasing investment in public health seems counter to that intention. You know, that ICSs will integrally, you know, really have to be linked very well to the public health system as both systems develop in their new forms. But turning then to social care, it's really complicated because it's part of the wider local government settlement. And so just to give you a few headlines and figures, and sorry that they're not on a slide that you can see, but so the headlines for local government are a 2% cap on the increase in council tax, plus a 1% cap on adult social care precept increase in the first year. And then that's an indicative level for the second 2 years. We don't know what the local government settlement itself is going to say yet. Now, that 3% increase delivers under £1 billion a year. So that's just a bit of context. And of course, councils have to decide to do it, whether it's an election year or not an election year, whether their council taxpayers have been hard pressed, etc., people on low incomes. So this decision has to be taken, but it's incorporated into core spending power. In addition, there's a £1 billion per annum grant for councils, which does not go up each year, so it stays at 1.6 billion a year. And it is for everything. So it covers COVID costs, it covers the increase in the NI, it covers the national living wage, it covers all services, but the government, I think, expects most of it to be spent on adult social care and COVID kind of recovery or scarring or whatever. But of course, all the other services are under pressure too. And then the final bit of funding is the funding for the social care reforms. And unlike the NHS, which takes its money from the levy to deal with its immediate pressures that it's got now because of the crisis and perhaps was already rising before, none of that funding for councils is to meet the immediate pressures. It's all to meet new responsibilities which are coming forward as part of the implementation of the Care Act Part 2 and also the new social care white paper. So set against that, local government's estimate of our forward, the LGA's estimates of local government forward pressures are around £2.5 billion per annum. So 7.5 billion per annum by 24-25. So think about that 7.5 against the figures I've just been talking about. Doesn't match, does it? It's not just adult social care, that's the whole council, but adult social care pressures in and amongst that are about £1.1 billion per annum. And that's before a lot of the inflationary increases and that, you know, so I think they're likely to be higher. And those figures look only at the forward pressures, like what's happening next. They don't look at what's happening now. And our estimate of existing pressures on councils is about 4.5 billion, of which 1.5 billion is adult social care market stability, which equates directly into that fair price for care conversation that the government's talking about. And 0.9 billion is public health, getting back to where it was, as David showed on his graph. You know, that is the bare minimum we think that ought to be done. If you want to go back to this ICS purpose, you ought to be investing more in public health. So the forward pressures we estimate will be met in years 1 and 2, but not in, there'll be about £1 billion short in year 3. And there's nothing at all to address the here and now. And what do we hear in the news all the time about the social care workforce, the inability to get domiciliary care, and not just domiciliary care. You know, not everybody wants that. People's care needs should be met in accordance with the Care Act. Their well-being should be supported. Prevention should be invested in. But there's no provision for that in these funding, except that the government would say, well, councils can decide how to spend the money we're giving them. But what we're saying is it's not enough to improve the system. And if the money for reform from the levy is signposted as being for that, well, it's going to come with new responsibilities, and 3.7 billion of it is to implement the charging reforms and to move towards paying a fair cost of care. So a really important point is that the here and now, the existing pressures are not being addressed. In terms of the reforms, 5.4 billion of that levy money is destined for local government. We don't know how it's going to fall yet. We know how part of it will fall. 3.7 billion will go through DLUC in order to implement the charging reforms and the fair cost of care. We estimate, based on the 2015 work that was done by the government, actually, that it'll cost about £1 billion to implement the reforms over the period of the next spending review. So some of that's set up and some of it's ongoing annual costs of assessing more people. And then we'll only be getting 200 million of that in 22-23, despite the need to begin the setup, but also to begin moving towards the fair cost of care. And the announcement, again, it'll be local government settlement when we hear more about that. But bear in mind that our estimate of what it would cost to deliver the fair cost of care, i.e. to take out the cross subsidy from self-funders, is £1.5 billion per annum. So we won't be moving very far or fast towards a fair price for care. The other thing I would say is that if you think about the national living wage increase, national insurance falling on care providers, which is not funded, and the particularly fuel and energy costs for care providers, really important parts of their cost base, there's going to be really big inflationary pressures, which are going to kind of sit against, are you moving towards a fair price for care, and make it very questionable whether it's possible to do that. Just by way of example, I was at a meeting with some councils in the Southwest last week, and they'd had their first letters from care providers asking for 7.1% uplifts in fees. And I don't think that is not the way in which council budgets are not going up by 7.1%, and adult social care is a big portion of their spend. And the remainder of that 5.4 billion is to help implement the social care white paper. And our worry is that will place new requirements on councils, when actually what we really need is to have the requirements in the Care Act properly funded, so that councils can do what they already should be doing, duty of prevention, duty around well-being, and making sure that we are investing in prevention and so on. So a worry that we'll be asked to do yet more, and in a sense be set up to fail in a world where we're about to, the government's about to introduce an assurance process for adult social care in councils, right in the middle of the implementation of all these reforms. I'll stop there, thank you.
Thank you, Sarah, that was excellent. Before you stop and we go to Saffron, can I ask you one very standing back question, which is lots of numbers there, lots of pressures. When you just look at the spending reviews, social care seems like one of the biggest losers in terms of where additional money's gone. You've told us a lot about what the pressures might add up to, how that might change over the years. Realistically, in very practical terms, what does that mean for councils, for care providers now? Is it standing still? How do local areas manage with the settlement they've been given? What does it mean in very practical terms?
So, there's still a lot of unknowns for councils because we don't know the distribution of the resources yet until we get the local government settlement. But I know that councils are already planning their budgets for next year. They'll have to be making some assumptions about how funding lands. If you exclude the reform funding, then most councils are looking at having to, make efficiencies or cuts yet again going forward. People are looking at making very difficult decisions because, the demand on children's social care is huge as well. It's in many councils that's as big or bigger pressure than adult social care. And then in other councils, so not all councils run adult social care, so there's really big challenges to district councils who support leisure and housing, which are also important contributors, of course, to meeting people's care needs and, of course, their underlying health and well-being, as we discussed earlier. So it's a really difficult, so the government will point to a 3% increase in core spending power. That includes the funding for the reform. It's about a 2% increase in core spending power if you take that out. And, the councils start from a base where there was already a problem. And we have got some councils have still got significant challenges flowing out of COVID, where council tax income hasn't recovered, where fees and charges income hasn't recovered. So there is a very big challenge for councils. Now, many councils do prioritise adult social care in their budgeting because they have to. I mean, they have statutory responsibilities around it, but they have other statutory responsibilities too. And they also have a statutory responsibility to balance the budget. So, they will be juggling as ever. And I think council's assessment of this spending review was that it was better than they had thought it might be, but still not enough to do what is expected of them in the way that it is expected.
Thanks, Sarah. So lots of trade-offs, lots of tricky decisions. Saffron, can I come to you to give us your overall take?
Thanks very much, Hugh. And yeah, I mean, I suppose first off, I think it's worth saying that obviously from an NHS perspective, it would be churlish for the NHS not to welcome the settlement that it got, given the share of public expenditure that the NHS does use. But there are still a whole host of howevers in that, because we know the scale of the pressures facing the NHS. So I just wanted to make a few points around that. The first point I'm going to make is that actually I wholeheartedly agree with everything that Sarah said. One of the key elements for us has been around the fact that if you seek to pull apart health and social care, then if you don't fund health and social care effectively together, then you cannot run either service effectively. We know that the interdependence is absolutely enormous. And this isn't just the straightforward bits that everyone thinks about, i.e. things like delayed transfers of care, being able to discharge people from hospital. That's absolutely critical, but it goes beyond that. It's also about the relationship, particularly in children's services, mental health, supported housing, all of those elements which kind of come with an effectively funded local government system and a social care system. So the first point I want to make is that it's critical for the NHS that local government is effectively funded, and that's been our position for some time. We're not going to say that the funding the NHS has received isn't welcome, because it is, but we know that there is much further to go. The second thing I think we need to look at is one of the points that Anita focused on, which is around capital investment. There was some capital investment announced in the spending review for the NHS, around £5.9 billion worth, which isn't a drop in the ocean. It is a significant chunk of money. However, we have been through a period where we have seen the capital to revenue transfers happening year on year on year, which does mean that we've been left with a situation where we've got backlog maintenance bills of around £9 billion. They have just grown every single year because we haven't been able to tackle them. And you know, whilst it's important to be able to invest in digital transformation, it's one of the key priorities and one of the key areas that is needing that investment. Actually, it's more fundamental that we can get those myriad kind of issues dealt with that actually undermine the efficient operation of the NHS. So every time you have a structural issue with a hospital, with a service, whether that's a digital issue or a bricks and mortar issue, that undermines the efficiency of the NHS, which means you're not deriving most value out of the money that you're putting in. And that's what we have to remember. On top of that, in terms of the capital programme, we know that there are huge challenges around the amount of money that has been made available for the new hospitals programme. We're not clear that that is going to be enough by the end of this spending review period to even get the initial phase of those redevelopments or new hospitals off the ground. So that's also another big challenge. I think that what we have seen is a massive national prioritisation of cutting the waiting lists, and it's totally understandable why this has been done, and it's really, really important. However, it's not the full picture, and I think looking only at elective waiting lists misses some big challenges out there in terms of the pressures facing the urgent and emergency care pathway across the NHS, the pressures facing mental health and community services. So whilst the elective backlog is important, and for those who are waiting significant periods of time for procedures, tests and other interventions, it of course is absolutely critical, but we have to remember that there are all sorts of challenges alongside that. And we have to also remember that whilst the announcements that have been made have been sizable chunks of money, what they need to cover is not only getting through the acute backlog, but also the huge increased running costs that COVID has brought with it, and also the ongoing pressures and demands that the NHS is facing with COVID, with other issues and challenges. So there is a lot there. The final thing I'm going to say, because I know we're a bit pressed for time, is that I think there's a lot about what isn't in this spending review, and I would point to the workforce settlement. We haven't seen that investment put into the workforce. So there was no budget announced for workforce planning, no long-term fully funded workforce budget, which is what we wanted to see. And that's absolutely critical, and it wasn't there. I'll stop there.
Thank you, Saffron. Thanks everybody for those reflections. I want to come back to that point you just made about the workforce. Clearly, staffing shortage is the biggest single challenge facing health and social care at the moment. And more money, how much, is not much good without more people. So talk to us just very quickly about what that means for trust the NHS right now. There's no long-term workforce settlement. There's no long-term strategy for expanding the workforce. How does that play out? What does that mean in practice for the pressures that we're seeing now, the pressures that we'll see grow next year, the year after? Well,
I think the thing it's worth remembering is that we're facing a number of pressures. So COVID has brought with it additional pressures, but the workforce challenges we're facing in the NHS are frankly nothing to do with COVID. COVID simply exacerbates them. They predate COVID. The level of vacancies of around 9–10% that we see across the NHS have been there. They're pretty baked in for some significant period of time, which is why we've been calling for the 3-year fully funded plan to grow workforce numbers. We cannot deliver a service without people. You can work more efficiently. You can think about how you kind of salami slice bits off of different services that you might provide, but fundamentally the NHS is already running on fumes rather than pure petrol, really, because it's depending on discretionary effort from staff already, and that's not unpaid overtime. Discretionary effort is people taking on extra bank and agency shifts, which they're no longer doing. So it's falling short on an ongoing basis. But put simply, without the people, you cannot deliver the services. So that means, I would say, continued pressure on staff, real risks of burnout over and above what we are seeing now, challenges to retaining staff as well as recruiting new staff, exacerbating the challenges we are seeing in some specialty areas where people no longer want to work. So it's really hard to get consultant psychiatrists, for example. So, you know, there's challenges across the piece there. And if you just bear in mind that in a community or mental health trust, workforce accounts for 80% of its budget. In a big teaching trust, it's around 60% of the budget. You know, it is basically, the NHS runs on people. If we're not going to invest in a plan to have that supply of people, then we are genuinely hand to mouth.
Anita, can you just help us understand, is this because the budget hasn't been decided yet? Is it because it's not going to come? It's confusing, it's muddy, and at the moment there's no budget. Are we waiting for something, or do we have to make do with what's been settled for NHS England? What on earth is going on here?
So I think the Treasury think that they've settled the budget for health as a whole, in that they've allocated the budget for the Department of Health and Social Care. At the moment, the workforce money comes out of the central DHSC, to use the initials, budget, and goes to Health Education England, and then NHS England has its separate budget. Treasury's view is Department of Health and Social Care is for you to sort out. And there's clearly also a wrangle going on, well, how much of the extra money that's been given to NHS England should in fact be used for the workforce. And then obviously now tied into that is this speculation in the Health Service Journal that they're going to resolve this in part by folding Health Education England in within the NHS. It's worth saying though, I think, you know, the issues in the NHS around the workforce are really serious, but actually the issues in the social care workforce are even more profound, I think. And the picture that Dave painted around the wider changes in the economy, the squeeze in the living standards, the rise in inflation, wage pressures emerging, which actually people are expecting, those are all going to really, really harshly affect social care, because social care wages are already uncompetitive. You know, the Treasury's answer on social care is, well, the minimum wage is going up. It is, and so that will help. The minimum wage is going up, but actually, with the minimum wage, many of the other sectors that social care workers could work in for better terms and less stressful work are already paying more than that. So, and across health and social care, one of the really big things in this is that if we can't create an environment as well where people can do a good job, feel like they're doing a good job and feel valued, we're going to really, really struggle. So funding for the system as a whole and the extent to which that creates a service where people can deliver quality and feel valued is as a big part of the staffing issue as well. You know, it's a vicious or a virtuous cycle, this.
Thanks, Anita. And you're right, vacancies in social care above 100,000 at the moment. I think, Sarah, do you want to come and describe a bit, what does the settlement do or not do to address some of those pressures on staffing in social care?
So not very much. So the reform funding has 500 million, a minimum of 500 million earmarked for workforce, but it's not for pay. it's for improving training and improving people's well-being. So yes, that's good, but I think that people, people need to be paid more. So there was an article in The Guardian yesterday which talked about how difficult it was to recruit personal assistants from an agency that specialises in that, because many of them used to come from Europe and they're now not coming. In the same article, it talked about the difficulty of recruiting a social care workforce when, yes, national living wage, applies to social care as well as supermarkets and leisure and hospitality, but social care can't always just put its price up to get more, to pay more in order to compete for staff, because it's largely a publicly funded service. And we go back to the settlement to local government, which doesn't provide for big above inflationary increases in payments to care providers. And they're probably going to struggle to meet the basics of the uplift, never mind increasing the pay. We reckon it would cost about £1 billion to move the social care workforce to the equivalent of NHS grade 2, which is where we see some of the job descriptions coincide. We actually think NHS grade 3 might be more appropriate, because a lot of workers have to work single-handed out on their own in communities without supervisional teams around them, and that would cost more. So there is a really big challenge there in terms of being able to compete, but also to even just get to the basics of equivalence with the NHS, never mind compete with, as the NHS is having to, with Aldi and Amazon and all the people that are paying bonuses to join their workforces.
So I want us to think a bit in this conversation about what still needs to be done and what on earth we do about this. We've got a social care white paper, I think, being drafted. We've got another one on integration between health and social care. What are some of the things that government needs to do in the short term to help, looking beyond the spending review, particularly thinking about the workforce and the sustainability?
It depends how short term you mean. I mean, probably some action. I think both the NHS and councils welcome some action over the winter to try and do something to attract more workforce in, and I doubt whether that can be done without more funding, or to retain the existing workforce. Actually, that's point one, is retain the people you've got, and second is recruit more in. But in terms of the social care white paper, looking forward to across the next spending review period, the funding that's available to implement that is 1.7 billion, of which 500, as I've said, is already allocated to that workforce training and well-being. There simply isn't the funding there to tackle the real underlying issue of the social care workforce and the need to pay higher fees. I think the government, to be devil's advocate, might say, well, we've put funding for moving towards a fair cost of care in our 5.4 billion that we've got. But actually, the issue there is that that's likely to be paying for the removal of the cross subsidy between private payers and publicly funded placements, and isn't going to be available to raise the pay of care workers in home care and in care homes and personal assistants and others.
Thanks, Sarah. Saffron, I want to come to you. Obviously, pressures in social care are important in and of themselves, and we should think about funding social care properly because of the benefits social care brings. But what at the moment are the knock-on effects of the pressures in social care on NHS services and the ability to move patients around the system and improve their health?
There's a really key and obvious one, and that is being able to discharge those who are medically fit. So I think that that's one element that is quite clear. And whilst we are seeing it this year, it's really come to the fore again. That's a pre-existing, long-standing issue and challenge that we've worked really hard to overcome. But it is in not being able to discharge patients who should be discharged because there isn't the capacity there is, of course, incredibly challenging. And what it means is that it then takes up the capacity that there is to treat more people, because staff are there looking after people who should be discharged. They are then unable to take other admissions, so whether that's emergency admissions or they will always take emergency admissions, but then that displaces the work that would be carried out on getting, for example, getting the waiting list down, carrying out diagnostic tests which aren't an emergency. So it's that knock-on effect impact. And I think the other elements that we see are also around, I think it's not just social care, is it? It's that broader basket of vital services that local government provides. So if we think about public health and the prevention role of public health, when we see that being eroded because the funding hasn't been put there, and that's, this isn't a criticism of local government not providing the service, it's a criticism of the funding not being put in place. So when other services aren't commissioned, or fewer services are commissioned because the funding isn't there, the kind of safety nets get removed. And we know that local government is a key safety net service, and some of those safety nets get removed, which means that people perhaps aren't saved from falling, I think is the best way I can put it. So someone who might be on the verge of a mental health crisis may well tip over the edge because they don't have the kind of community infrastructure that's there. They don't have the support that they need from drug and alcohol services that haven't been able to be commissioned. That means that they come into contact with more statutory services or NHS services later, which means that they are sicker, which means that they are more difficult to treat, takes longer to treat, so it undermines the overall capacity. And again, this isn't a criticism of local government, it's a criticism of the structures we currently have in place and the funding routes that we've got. So it's so important to remember that there are so many knock-on effects of massive undermining of the local government funding base, basically.
Really helpful response, Saffron. We're getting some good questions come in, and one that logically flows from this, which is that we've got these new things, or not that new, but these things called integrated care systems, a bill going through Parliament to make them real things in April next year. And one of the big hopes is that they'll be able to redistribute money in the system, prioritise prevention, shift resources around, but also some worries, some fears they might become dominated by acute hospitals, for instance, which is either a good thing or a bad thing, depending on your perspective, that they might not prioritise prevention. To what extent do we think that the shift to integrated care systems is going to help here, given the settlement that we've got and the limitations of funding in some areas and not others? So Saffron, can I come to you first on that? How will integrated care systems help or not help to achieve some of this reallocation? And Sarah, I'll come to you on the same question.
So I think integrated care systems in and of themselves are incredibly helpful. So they, particularly in those places that have well-established relationships already, where they have a good history of partnership working, or perhaps they've had a relationship that's been kind of kick-started by the pandemic and they're able to build on that. So I think where those pre-existing relationships and structures are in place, we've probably seen quite a lot of places doing this already. So I think they are, of course, helpful, but I think we shouldn't overestimate their ability to be able to make this money go way further. I think what they should be doing is improving the experience of people. That won't necessarily be cheaper, but it might mean more joined up care, and it might mean that we can deploy staff more easily across different services, and we might be able to plug some gaps. But I think if the notion is that integrated care systems are going to build in some massive efficiency savings, I think it will be a long time before we see that return. I think, it's because they will be there over time to support the prevention agenda, to support the public health agenda, to get to people before they get too seriously unwell. However, that comes in a few years' time, doesn't it? It doesn't come in right now. And right now we are facing some very, very significant pressures and demands, which will actually increase what the NHS needs going forward, because we're digging, you know, I don't like this phrase, but I can't think of another one now, and it's stuck in my mind. We're digging ourselves a deeper and deeper hole as demand goes up. And so unless we can get ourselves out of that, then it gets even more difficult. So there is lots to be hopeful about in terms of integrated care systems and changes to how we are cooperating and collaborating. But you know, it's not a magic wand, and it's taking loads of resource to manage and run integrated care systems, and it's taking lots of leadership time to do that. So we have to remember that too.
Yeah, and as you say, the evidence doesn't tell us that integration saves money. It might improve patient experience and pathways. I guess there's a question, and coming through here on the chat, is there a chance to reallocate resources and invest in some things more than others? But Sarah, to you for your reflections on whether integrated care systems might help.
Yeah, so I think a lot depends on whether the intentions set out for integrated care systems, whether they're followed through. And that includes through assurance processes, performance management. So what does the NHS expect of integrated care systems? Does it genuinely let them shift their investment into prevention, or to do the things they think are right in their local area? Or does the waiting list or the waiting times or the, you know, dominate the performance measurement? So are we measuring whether we're, and I think this is a question for the ICS assurance work, you know, in terms of assuring them, are we measuring what we expect them to achieve, which is improved population health, or are we measuring the same old indicators? So not that the other indicators aren't important, but we have to expect something different in order to be able to see it. The other thing I would say is that it would depend how well the, so part of the expectation is that there'll be a principle of subsidiarity, that there will be integration will be more at place level, not at system level, building on what's already there. And again, will that be allowed to happen? Will there be genuine sort of delegation and devolution of powers within the NHS, and not the overruling of pooling or shifting of investment into preventative or community services? So the other just final point I'd say is that, you know, joining two leaky buckets together, one with a gaping hole in and another with a few like bullet shots in it, doesn't necessarily, you know, make a bucket that works. And one of the things we do need is dedicated investment in community infrastructure, you know, and whoever's it is or whatever it's for is less important. And in our spending review bid from the LGA, we proposed a community investment fund, which would start at £1 billion in next year, rising to 3 billion, to invest in, you know, yes, preventative services, community capacity, but also, you know, not only around like the things that would support adults, but actually families, because actually that's where good health starts. So early intervention, parenting, but also even adult education, those sorts of things. And of course we weren't successful in that, but it was a kind of attempt to say community capacity is so important to success, and it's not something it's not an eligible service in social care terms, and it's not something that the NHS would fund, but if we haven't got it, we all miss it.
Can I, Anna? Oh, go on, Saffron. Go on.
I just wanted to come in on that point around. I think the community infrastructure point is absolutely critical, and particularly thinking around children's services and what we know has kind of flowed away from the investment in children and young people over the last 18 months or so is absolutely fundamental. And I think, you know, from an NHS perspective, across mental health, community services, we are really, really concerned, and public health as well, I think, really, really concerned about what we are storing up for the future in terms of longer term life outcomes, life chances for what's happened to children and young people during this pandemic, building on, it's put a bigger hole in that leaky bucket, frankly.
I want to move us in a second to NHS capacity. We've got some good questions here about the relationship between spending and when capacity comes on stream, but I also want to talk about public health and what the settlement means. So at a place level, building on this conversation, it looked like from the slide Dave presented was, I think, public health grant being maintained, but basically lower than it once was, 2015, whereas needs seem to be increasing. So Sarah, in practical terms, what does that actually mean for the money available for interventions that we know can improve health, reduce inequalities, Is this cuts? Is this reallocating resources? What does it mean, practically speaking, for local authorities who are having to work out what they do with this public health budget?
I mean, basically, they'll have less funding to do this. So real terms funding. It depends whether that includes accounting for population growth, because obviously the whole time the grant's been cut, but the demand's been rising. Councils did a good job of recommissioning some of the social care services. We have produced a report that shows that they're spending less but actually getting more. But nevertheless, there's a limit to how much you can do that. So a lot of those efficiencies will already be taken. So there may be some areas that can, through commissioning, get a bit more, squeeze a bit more out of the money they've got. But what we won't get is substantial further investment in preventative measures, particularly things which, have been shown to be really important in the pandemic, like reducing obesity, smoking cessation. Yes, I mean, that's an ongoing program, and you would expect perhaps less to be spent over time relative to other forms of public health intervention. But we know that drug and alcohol treatment, is under huge pressure, and we need to be, so much of this, comes to people too late. It's back to the community infrastructure, isn't it? Where you need some of the investment in the charities that work in this space to prevent people getting to that point of needing that treatment. And the public health, the way public health budgets are set is not allowing that, scope for that investment, which would really help.
Anitra, I'll come to you, but just quickly first, Dave, can I also come to you on this point of public health budgets? And I guess also standing back, I guess health has been prioritised here. Healthcare has been prioritised over a long period of time. That means it's eating up a growing share of public spending, and we'll have a bigger share of public spending by the end of the Parliament than is now. So what does this spending review tell us about government's priorities for improving health? And then specifically anything you want to say on the public health grant to build on what Sarah's pointed out?
I mean, I think, as you said, when people talk about health and health being a priority, particularly kind of in public opinion and so on, it does tend to be about the NHS. And I think that's ultimately where the focus then of the spending lies. And I think that's, it's quite clear through the settlements over numerous years now. I mean, this year obviously is, it is a positive thing that you've got this extra investment there. I think what will be, really important going forward is how far there is actually good coordination across government to look at how different departments can improve health. So there is a new, cabinet task force looking at this, which is bringing together the different departments, I guess. And I think that, the important thing will be that is something that goes broader, I think, than focusing on some very acute health issues, and takes that longer term preventative approach, so that we are trying to, so there is like good cross-government action on trying to keep people healthy in the first place. I don't think that can be a quick thing though, is one of the problems, and that's partly because of the shift in spend that has happened over the past decade. I mean, particularly when you look at some of the local government programmes, things like even things like housing, where you have seen a shift away from kind of more payments that help support people struggling with rent, because that funding has effectively been cut back, and a greater focus on dealing with people who have become homeless. And I think, and it's quite symbolic of this shift away from trying to keep people healthy in that preventative approach, and into one where you're tackling acute need all the time. So I think that's, there's potentially mechanisms coming through, and we've had, the realization of the scale of health inequalities through the pandemics. We can hope there is a focus there, but the spending settlement is ultimately pretty tight on those things to actually, to keep things as they are, or keep dealing with the acute needs you have now, and make that extra investment so that things are better in the future, is going to be, really hard to do. I think on the specifics of that the public health grant, so the commitment was maintaining in real terms. So we've taken that to mean purely about, effectively like inflation costs, and not things like wage growth factored in, or population growth either. And so, we would expect effectively then that we are, even just on those basis and those wider trends of things like the growing trends of things like alcohol and drug deaths, and projections of growing child poverty that place greater pressure on children's services, that effectively it's providing, you know, the demand is growing, but the money's staying the same essentially. So we're going to be able to tackle that less.
Okay, and Anita, did you raise your hand a little bit on this point and want to come in on? Oh, she's gone. She's disappeared. Raised her hand slightly and disappeared. Okay. Well, I want to swing over to NHS capacity then. So far, we've got a really good question. We've got someone called Stuart, which is we're increasing spending. You talked a bit about capital, but we've had a period where capacity's been really constrained. We entered the pandemic with fewer doctors, nurses, equipment than most comparable countries. So how quickly, you know, even if we increase spending to the levels that have been recommended, for instance, on some of Anita's slides, how long does it take to translate the new money into people, equipment, resources to expand services? We've got acute short-term pressures now. We've got record levels of pressures that clearly are not sustainable, despite government saying sometimes that they are sustainable. How long does it take to translate extra spending into the capacity that we need?
Well, I think some of that comes from how long it takes to train staff and bring them on board. And we know, you know, for the NHS, that can be anything between a couple of years or 5 or 7 years or 10 years, depending on the specialty and the level at which someone's coming in. So that it's a medium to long term challenge and issue, I think, in terms of the workforce. I think what we do know, however, is that the NHS is in real time reconfiguring its services and thinking about how it does things more efficiently and effectively to get around some of the curveballs and challenges that COVID has thrown us, which I think is actually helping to make best use of that capacity. So things like the hot and cold sites that on the acute side of things. So the hot and cold sites that we are seeing, whereby lots of ongoing elective care can be carried out whilst, you know, saving, in inverted commas, the emergency capacity for other parts of a hospital's estate. So those kind of efforts and elements are really helping. I think digital transformation is helping to really bring in new approaches which are less labour intensive, frankly. So outpatients appointments being done virtually, greater use of nurse practitioner and specialist support nurses to really triage even more effectively. And we know that there are going to be some proposals brought forward relatively soon on thinking about how we can look at things like outpatients in terms of the elective recovery plan and free up more consultant time to be getting through those waiting lists. So there are all sorts of things being done differently, but in terms of how we're going to get through this backlog, not just, and this isn't just in acute care, and I do have to keep stressing this, you know, we did a survey recently and we asked all of our trust leaders where they thought how long it would take to actually get back to usual. Mental health trust leader said anywhere between 2 to 3 years to get their activity back down and through their backlog and waiting times to a pre-pandemic level, where we know that, you know, there's a massive care deficit in mental health anyway. So actually not treating everyone we need to treat in a mental health context, but even to get the waits down to those pre-pandemic levels, 2 to 3 years. So, you know, this is a medium-term endeavour. This isn't immediate stuff.
And I'm going to come back to Anita now. She's back with us in a second. But Safwan, just quickly on mental health, we've had a couple of questions come through. I'm glad you've mentioned it. Where we know that the pandemic is likely to have increased need for some mental health support. What did we see in the spending review for mental health? Is there any change here? What's the outlook? Don't worry if you can't be too specific. Is there anything that we've learned from the last month or so?
So I think this is a really interesting one, actually, because I think the ongoing spending commitment is there for mental health. So we know it's going to be looking at, you know, things like maintaining the funding for the long-term plan, the mental health long-term plan. However, this spending review period goes beyond the end of that long-term plan period, so we're not quite sure what happens to the money after that. There might be a little bit of a cliff edge there. I think there has been a small amount of capital investment for mental health, 50 million a year over the next 3 years. The mental health investment standard is still in place. I think my beef on mental health is that it hasn't been explicitly spelled out or communicated what this settlement does mean for mental health services, and is it taking on board all of the additional things. A bit like the social care story that Sarah tells, there's additional stuff coming down the track that mental health trusts will need to deliver. The Mental Health Act implementation, once it finally makes its way through Parliament, you know, things like access standards, waiting time standards, which is really welcome for mental health services, but are they being factored in terms of the spending review? I think it's, you know, there's an overall settlement that has come to NHS England and improvement, which will include expenditure for mental health. But I think we need to wait for the planning guidance that should come out, hopefully before Christmas, that will tell us how that money is going to be spent. And I say hopefully, and I saw the wry smile from Anita there, you know, that will tell us how that money is going to be allocated to mental health, because it's been a little silent from my perspective.
Thanks, Saffron. Anita, you had a few things come up, but can I just throw in, when you're away, there was a question that I thought would be helpful for you to give some reflections on, which is, we've got increase, for instance, in capital spending, got increased spending more broadly, that clearly needs to translate into resources, people, theatres, whatever else to do the work. How long does that take? So when do we expect to see the increased spending, particularly given the decade we've had of underinvestment? But also, you've missed a few questions, so any other reflections you want to throw in?
Yeah, I was going to pick up a few things together. Sorry, our internet went down in the office. I was going to pick up a few things together here, because actually I think one of the really important questions, some of this, is to what extent the long-term plan objectives that predate COVID, where a quarter almost of the money that's going in over the next few years in that underlying increase is ring-fenced for mental health, community and primary care. And a lot of that is about developing new capacity, more capacity, but actually doing things in different ways. And one of the things that's quite interesting in both of those is the extent to which it's looking a little bit to break out of or push the boundaries of the biomedical model and create some new workers who work in different ways. So about a fifth of the extra workers that are planned to go into mental health are peer support workers. And then if you look in primary care, there's all the social prescribers and stuff. And I think one of the things is, are we still committed to all of that agenda out of the long-term plan? If we are, and that is toppermost of the ICS agenda coming out of this planning guidance, the COVID pandemic, you know, has created some opportunities of different ways of working for different seeing things and interconnectors, and the issues that Sarah, Dave and Saffron have been talking about, for example, about children. Do we need to have a little bit of a think and go even further with that? If we're going to spend a quarter of the extra money on these services, could we go further and be bolder and even be more imaginative than we were thinking of doing then, to deliver things in a different way? And that's part of the answer to your capacity, yeah? Because if we're going to build traditional health service facilities with traditional health service workers, it's going to take quite a while, yeah? But actually, if we want to use this money to do some really different things, yeah, that has risks and that has a lead time because you have to find the new things. But we fast-tracked some stuff through COVID, and actually some of that we could perhaps scale up faster than the traditional models. So I think a bit of a pause to relook at the 40 hospital programme and saying, are we building exactly the same as before? Do we need to actually pause a bit so we can then go faster? It would be good at the moment.
Thanks, Anita, and perfect timing. A good place to finish, I think, the consideration to reflect on the objectives in the long-term plan. The broad principles seem the right ones. How far we can achieve some of the objectives seems more challenging. Our time's up, so I'm going to stop here. This has been a really, really rich discussion. Thanks so much for the questions that you've asked, and thanks to the panelists so much and the speakers for your reflections, presentations, responses. We haven't covered everything. There's so much more we could have talked about, so please do tweet the questions, email us with the questions, and we can try and get to them. The webinar has been recorded and it's going to be available on our website to watch and share with your colleagues. So please do send the link to people. Registration for the next Health Foundation webinar is open, which is going to focus on COP, the fallout from COP26, and what it might take to get the NHS to net zero. So please do sign up for that. We'll put a link in the chat now, and on the slide I can see there's some information too. I'm going to run out of time in a second, so the last thing is just thank you so much for coming. I hope you found the session valuable, and goodbye, and hopefully see you next time. Cheers.